Hello everyone. This talk, Vitamin D in Dermatology, is intended for dermatologists and other doctors who are interested in treating skin diseases. For others, the technical terms used may not be very comprehensible. Sorry about that. Vitamin D, also known as the sunshine vitamin, has been implicated in many medical illnesses, including a number of skin diseases. Skin is the organ of production as well as target organ for vitamin D. It is becoming increasingly evident that the functions of vitamin D in differentiation, proliferation, apoptosis, barrier, and immune functions of the skin are complex and all encompassing. Now, vitamin D is not just a modern day snake oil, as some people tend to think, nor is it an optional supplement anymore, but a very necessary cellular necessity, absolute necessity, we must say. This talk will highlight this important aspect of the sunshine vitamin. Vitamin or vitamin, which one is correct? Both are correct. One is used in UK, one is used in US, and we can use any. Vitamin D, as we all know, is a fat soluble vitamin, and its functions are like a hormone rather than a vitamin. There are mainly two forms of vitamin D, D2 or ergocalciferol, which is derived mostly from the sun grown mushrooms, and D3 or cholecalciferol of animal origin. There are many sources like salmon, sardine, egg yolks, beef liver, etc. etc. Vitamin D3 is the active form of vitamin D, and of course, the best source is from the sunlight. The classical function of vitamin D involves mineral balance, especially that of calcium and phosphorus, and skeletal maintenance. This has been known for a long time, and mostly in the earlier days during our MBBS days, graduate days, we used to study about vitamin D and the calcium metabolism only. But nowadays, the latest findings and latest studies have shown much higher functions of vitamin D in the body. These are the non-classical functions, which involves decoding of genetic information in the DNA of cells and helping the cells to carry out their specific functions. This is very important. This is what we are going to see in detail today. It is to be noted that vitamin D receptors are present in all the cells of the body, including the skin cells. It is important to remember that rickets is just the tip of iceberg, and vitamin D deficiency have far-reaching consequences than previously thought of, as it has a long, lifelong impact on each of our organs. As mentioned earlier, vitamin D is also a hormone. It is actually known as a prohormone with both endocrine and autocrine functions in the body. It is a hormone because it is synthesized in the body, and a vitamin because it is also available from food and supplements. This is the overall metabolism of vitamin D. The most, I would say, the most important slide of this talk. It shows the metabolism of vitamin D in our body. 7-dehydrocholesterol, which is a derivative of cholesterol in the skin, is converted to pre-vitamin D. This is the pre-vitamin D via the ultraviolet B irradiation from the sunshine. The ultraviolet B with the range of 290 to 315 nanometer range acts on the skin to convert 7-dehydrocholesterol to pre-vitamin D. Then this pre-vitamin D3 is thermally isomerized to vitamin D3, meaning it needs heat for this conversion. Both vitamin D3 spontaneously formed in the skin and available from the diet and supplements are then taken to the liver for storage as well as for a conversion to um, circulating and storage form of vitamin D3, that is called 25 hydroxy vitamin D3. This is done in the liver. Finally, this is still, it is in the inactive form. This cannot act on the cells. It is in the inactive form. It is only the storage form and the circulating form. And it is bound to the vitamin D binding protein in the blood. Now, this inactive form is further hydroxylated to the biologically active form, the 125 dihydroxyvitamin D3, popularly known as calcitriol in the kidney. From now onwards, we will use the name calcitriol for the active form of vitamin D in this talk. Now, the production of vitamin D in the skin is directly proportional to sunlight exposure and inversely proportional to the degree of pigmentation of the skin. The darker the skin, the production of vitamin D will be less, meaning that you need more exposure to sunlight than the fairer skin to get appropriate amounts of vitamin D. Serum concentrations of vitamin D3 usually peak by 24 to 48 hours following exposure to UV radiation. And the serum half-life of 25 hydroxy vitamin D, or the inactive form or the circulating form, is approximately 15 days. But after the storage in our adipose tissue, the vitamin D3 prolongs its total body half-life to approximately 2 months. This also has to be remembered. That means you don't have to expose to sunlight regularly. If you expose to sunlight one day, it will be sufficient for a few days. So in a week, at least 3 days exposure is essential, and that will be sufficient for most people. How much time? Almost you have to expose for minimum 20 minutes to half an hour. For very dark skin, you have to expose a little longer, say 45 minutes. And the whole body, if you can expose, it is well and good. But if you cannot, at least expose your upper part of the body, hands, and the feet for 20 to 30 minutes. So this will provide you with sufficient amount of vitamin D. It is also to be noted that if in case of liver or kidney diseases and failure, the vitamin D activation can be affected, but not 100%. You will see why. Because in organs like the skin, there are the enzymes required for the conversion of inactive vitamin D3 to active vitamin D3 is available, and it occurs. So even in case of complete renal failure, if you expose to sunlight for a particular time and take a balanced diet, that will provide you with sufficient amount of vitamin D3. Now, vitamin D mediates its function in the body by binding to the VDR, or the vitamin D receptor, which I have already told you is present in each and every cell in our body. It is also a member of the nuclear hormone receptor superfamily, which includes RXR, that is the retinoid X receptor, vitamin A receptor, and also thyroid hormone receptors. So there are many receptors in that family. So VDR belongs to this superfamily. It is activated by vitamin D when it interacts with RXR. VDR is activated by vitamin D and interacts with RXR, forming a heterodimeric complex with the DNA of the particular cell. The target genes in specific cells and tissues are then activated or their expressions regressed, either activation or deactivation, whichever is required for that particular demand from the body, through interaction with additional co-regulators also. There are additional co-regulators also. It is important to notice that though we are talking about vitamin D, it's not a standalone nutrient or a standalone hormone. It can work only in conjunction with other vitamins and other hormones. So please remember this, and of course the nutrients, other nutrients also. Does all this sound a little complicated? Let us make it a little simple. This is the heterodimer complex that is formed with DNA by the VDR and RXR nuclear receptors within the nucleus of the each and every cell. Whenever there is a demand from the body to produce particular proteins, this is what happens. The activated vitamin D3 or the calcitriol enters the target cell and binds to its nuclear receptor VDR and activates it to combine with RXR, which combines with the DNA and a number of cofactors and regulate the gene expression from the DNA to produce specific function of the target cell, like the specific functions. It could be apoptosis or increasing the cellular death that can limit spread of cancer cells. It could be immune regulation, either innate immune, the specific primary immune barrier of the body, or anti-inflammatory action against inflammatory diseases, and in the differentiation of cells. So these are many functions are there. Each function of the cell is mediated through this VDR, RXR, and cofactors combination. This is a simplified illustration of how a cell responds to vitamin D and its receptors. Whenever there is a signal or demand from the body to a particular cell, say for example, let us take an example of the beta islet cells of the pancreas. Whenever there is high blood sugar levels, the calcitriol goes inside, binds to its VDR or the VD receptor, and along with RXR companion, it's a RXR companion, it decodes the DNA information of the islet cells to transcript the production of insulin. In other words, the VDR or the vitamin D is the key that unlocks the DNA library. So the DNA library, which contains the information of the specific functions of the particular cell, is unlocked, and that function is expressed through this combination of VDR and RXR with the DNA. This is, in short, about the how a cell responds to vitamin D and how a cell responds to demands in the body. And this, after production of the particular cellular equipment, cellular product, the response is given. This is how a cell responds. It may be, as we have already seen, the islet cells of the pancreas. It may be the macrophages, which limit the attacks of viruses and bacteria. And it can be muscles, which has to contract for any function or any activity. So these are all controlled with this heterodimer combination of RXR, VDR, and cofactors with the DNA. Now, it is very easy to understand after seeing what is happening. If the amount of vitamin D is normal, is adequate, along with other nutrients, of course, then for any stimulus, there is a proper response from the cell. Simple. We can understand that. Now, imagine if the vitamin D levels and the levels of the micronutrients along with it is low, then after the stimulus, the response will not be very proper. It will be low. So the for the sufficient cellular function, we need sufficient balance of vitamin D in the body. It's as simple as that. Not only vitamin D, all cellular micronutrients that our body requires, all vitamins, microminerals, and other phytonutrients, everything. This is what we have been talking. Vitamin D is not a standalone nutrient. It acts synergistically with other vitamins like vitamin A, vitamin K2, vitamin C, and vitamin E, along with minerals like magnesium and zinc. Magnesium is very important because it vitamin D requires magnesium in each of its steps to become active. Hence, it is essential that we give multivitamin and multimineral supplements along with vitamin D whenever we detect vitamin D deficiency. I've seen lots of prescriptions from many doctors giving only vitamin D whenever there is vitamin D deficiency. This is wrong. We have to give along with vitamin D a multivitamin supplement, or insist to the patient that they take a well balanced diet with proper good amount of vegetables and fruits, fish, and sufficient carbohydrate and proteins. So this is very important. Hence, in other words, a well balanced diet is very important along with proper sun exposure for the vitamin D endocrine system to function properly. Now, when we understand the effects of vitamin D and its receptors in each and every cell of the body, it becomes easier to realize how vitamin D suppresses aging signals in our body. It encourages autophagy, that decreases aging, and it has got an inhibitory effect on all these functions: mitochondrial dysfunction, oxidative stress, inflammation, calcium signaling, epigenetic signals, DNA disorders, and telomere shortening. All this which causes aging is inhibited by vitamin D. Means vitamin D regulates their proper functioning. So it is essential for us to keep an optimum level of vitamin D, not only for in the matter of skin diseases, for all diseases, to prevent our body into going to the illness mode rather than the wellness mode. Now let us quickly glance through the role of vitamin D in skin diseases. We have already seen the metabolism. Now we understand. It is very easy to understand how vitamin D acts as a protector against a multitude of skin diseases. It has also been linked to a large number of other human diseases. You can see the list. The list is almost not just what is shown on the slides. There are so many, because of course it is understood the vitamin D is there in each and every cell of the body, and whenever vitamin D deficiency is there, it affects the normal functioning of the cell, and it goes into the illness mode. And we have to understand that almost 3% of our human genome is regulated by the vitamin D endocrine system. And in the skin, the integrity of the whole skin is connected to a proper amount of vitamin D, its synthesis, its metabolism, and activity in the body. Vitamin D regulates many physiological processes in the skin, ranging from cellular proliferation, differentiation, and apoptosis to barrier maintenance and immune functions. We will see one by one. In short, I'm not going into details because of this. Vitamin D also plays a very important role in hair follicle cycling, sebaceous gland regulation, and photoprotection, and of course in wound healing as well. Both calcium and calcitriol perform important interacting functions in regulating the skin differentiation process, mediated through various key epidermal proteins and cofactors and enzymes. like the involucrin, filaggrin, transglutamase, etc. The epidermal differentiation is a very important function that occurs continuously without any break throughout our life. The basal cells produce the cells, and these cells come upwards through three layers, and then the final layer, the cornified layer, which protects our body from outer the environmental harms. So this differentiation is very important in protecting the body against many diseases, and vitamin D has a very important role in regulating this differentiation process. It also is as a effect on our epidermal barrier function. It is mainly by enhancing synthesis of structural proteins of the cornified envelope, that is the stratum in the stratum corneum. Calcitriol and its receptor regulates the processing of the long chain glycosyl ceramides that are very critical for the skin barrier formation. There are other mechanisms also, but these are the two main mechanisms through which the vitamin D helps the skin to maintain its barrier function. At physiological concentrations, vitamin D prevents apoptosis triggered by various injurious stimuli like ceramides, ultraviolet radiation, TNF alpha, that is tumor necrosing factor alpha, etc. This is very important and a process which contains the skin cells from overgrowing or causing cancers. But remember, at very high concentrations, vitamin D can induce apoptosis in keratinocytes as well. So we have to be very careful not to go for very high concentrations. An optimum level of vitamin D is considered as 40 nanogram to 60 nanogram. Up to 100 is okay for certain people, but above 100, be careful. Above 150 nanogram per ml, it should never go. It will cause toxicity. But what we see is many people are afraid of vitamin D toxicity and keep on maintaining the patient below the subnormal levels of vitamin D. Now, the normal levels are not, we'll see later on, 30 nanogram per ml. This 30 nanogram per ml was decided or many decades ago when vitamin D was supposed to work only for the calcium metabolism and the bone mineralization. But now it is not so. Each and every cell requires vitamin D. So a level of 30 nanogram per ml is not sufficient actually. Though we say it is a sufficient level, optimum levels are near 50. 40 to 60 is the optimum range of vitamin D that we should aim for. This is the vitamin D signaling pathway in innate immunity, the first line of defense against invading organisms. Now we know the most dangerous and most current invading organism is the CO2, SARS-CoV-2 virus or the COVID-19 virus. Vitamin D, you can see here, when the pathogen enters through the toll-like receptor, vitamin D through its VDR, this is the macrophage. In the macrophage, induce this TLR receptor 2 and initiate the innate immune response in the skin. This is through the activation of these receptors, the vitamin DR as well as RXR receptors leads to the expression of the gene cytochrome P27B1, which in turn induces the DNA to produce antimicrobial peptides, cathelicidin and defensins. These are the AMP or antimicrobial peptides. That is the first defense against invading viruses and bacteria in our body. And this, once cathelicidin and defensins are released or manufactured, this results in phagocytosis and killing of the invading organisms. So this is the most important step in the first innate immunity, and vitamin D signaling pathway shows us that it is very important to have a proper level of vitamin D to have a proper immune response to any invading organisms. This is indeed the first line of protection against COVID-19 too. In the mucous membranes of our nasopharynx. Remember the loss of smell and the loss of taste as one of the first symptoms of COVID-19 in many patients. Some patients don't experience it, but actually, this is a very good symptom. Having loss of smell and loss of taste early in the infection shows that our innate immunity is intact and working well and trying to protect our body against invading virus. So the most probably if the invading virus has been stopped at the port of entry or the route of entry, the patient may not go into serious type or moderately severe type of the disease. Now, early studies of vitamin D and the immune system demonstrated that VDR expression is there in both T and B cells. Both T and B cells have got VDR, that is the vitamin D receptors, and the helper cells appear to be the principal target of the vitamin D. Vitamin D down regulates the Th1 and upregulates the Th2 and also regulates the cytotoxin productions. That is the interleukin productions within the body. This is very important because it regulates the inflammation and also autoimmune tendency in the organs, including the skin. The tight regulation of cytokine production by vitamin D plays a very vital role in limiting cytokine storm in COVID-19, as well as in situations like the explosive erythrodermic stages in diseases like psoriasis and drug eruptions. So having a vitamin D normal levels is very important in preventing such occurrences. Now, a large number of studies have shown well-established role of vitamin D in pathogenesis and treatment of psoriasis, as well as in treatment of LSEA, that is the lichen simplex atropicus, and morphia. There are some conclusive but mostly inconclusive evidences, but compelling evidences regarding its role in atopic dermatitis, vitiligo, ichthyosis or dry skin, keloids, and other autoimmune diseases of the skin. Its role in skin cancer prevention is also prevalent and studied well, but not yet confirmed. So it is yet in the controversial stage. Having said that, it is to be noted that the levels of evidence and grades of recommendations regarding the role of vitamin D in major skin diseases are pretty convincing. You can see majority of studies are showing level 2, that is evidence obtained from at least one well-designed multi-centered RCT, randomized controlled study, especially in psoriasis, atopic dermatitis, vitiligo, systemic lupus erythematosus, polymorphous light eruptions, alopecia areata, and skin cancers. And control trials, without control trials, level 3, showing in ichthyosis congenita, and 3 is in hidradenitis suppurativa also. So there are evidence, but of control trials without randomization. The beneficial effect of vitamin D, both topical and systemic in psoriasis, could be due to the promotion of differentiation, inhibition of keratinocyte proliferation, immunomodulation of the activated T cells, and regulation of inflammatory cytokine activity. And also its actions on the apoptosis of the skin epidermal cells. So this almost covers the whole pathogenic mechanisms of vitamin D. So it's very important to whether we can keep our vitamin D levels well. Psoriasis can be kept under control, or maybe in those people who have got their vitamin D properly kept and leading a well balanced diet as well as well balanced lifestyle with stress management and avoiding the triggers, psoriasis may not happen at all, even in the genetically predisposed. This is something that we should look forward, study well, and make sure that none of our patients are vitamin D and other micronutrients deficient. We all know about the most prescribed medication for psoriasis for more than 2 decades now. The vitamin D analogs, the calcipotriene, calcipotriol, all these, and their effectiveness in controlling mild to moderate psoriasis is unsurpassed so far. There have been so many latest medicines, so many are there, but still, this is the most prescribed medication in the whole world. There are a few studies showing that high dose vitamin D3 therapy is effective and safe for psoriasis as well as in vitiligo. But here we have to be very careful. It is very important to put the patients on low calcium diet with an increased hydration, because hypercalcemia and renal damage are the main concerns with high dose of vitamin D supplements. So we have to be very careful to avoid such complications. Hence, it is very essential that we do tight monitoring of vitamin D3 at high doses, like the vitamin D3 levels, the parathyroid hormone levels, ionized calcium and total calcium levels, urine calcium excretion, the renal function test, alkaline phosphatase test. All this should be done during such a therapy. Now, coming to atopic dermatitis, many studies suggest that vitamin D deficiency in a genetically predisposed child can lead to the development of atopic dermatitis. Vitamin D, as you can see, can influence the course of atopic dermatitis through its effect on the epidermal barrier, the strengthening of innate immunity to skin bacteria, and promotion of tolerance and reduction of the Th2 immunity. So, like in psoriasis, in atopic dermatitis also, vitamin D plays a very important role. Majority of studies so far has found a positive role for vitamin D supplementation in atopic dermatitis, while a few have not found any significant statistical difference between the controls and vitamin D treated patients. We will discuss about this anomaly later on, because this is important to know that why such thing is happening, why there are at the same time as positive studies, why there are so many negative studies as well, not only in vitiligo and psoriasis, in many diseases, not only skin diseases, in other other diseases like heart diseases, cancers, and bone diseases and autoimmune disease, all everywhere we see this anomaly. We will discuss this later at the end of the talk. Regarding vitiligo, vitamin D protects the epidermal melanin unit and restores melanin integrity via several mechanisms, including activation, proliferation, and migration of melanocytes and pigmentation pathways by, of course, modulating the T cell activation. As we all know, these are all autoimmune diseases, and vitamin D has got a very important role to play there. The use of vitamin D analogs in combination with Vuasol and topical calcipotriol is indeed beneficial in the treatment of vitiligo. This has been shown in many studies. Vitamin D has an important role to play in acne too, as sebocytes in the sebaceous glands are vitamin D responsive target cells. Also, the Pityrosporum acnes is a potent inducer of Th17, and vitamin D3 has been shown to inhibit P. acnes induced Th17 differentiation. I'm not going into too much details for lack of time. Promotion of cell differentiation and apoptosis, along with inhibition of cancer cell proliferation, inflammation, and angiogenesis by calcitriol, may explain the cancer protective benefits of vitamin D. Many studies are coming up showing these effects of vitamin D on prevention of skin cancer and as a complementary treatment along with the specific treatments for each skin cancers. Topical vitamin D analogs are the best and established treatment modalities in morphia and LSCA because of already we have seen its effects on the immunoregulation, fibroblast proliferation, collagen synthesis, and endothelial cell functions. So it's a multi-functional approach for vitamin D in diseases involved with skin fibrosis. Also, several studies have found a correlation between the degree of skin infections and a low vitamin D. Recurrent skin infections always check vitamin D, serum ferritin, thyroid levels, and other. Take a detailed history of patients' uh, nutrition. This is very nutrition as well as the lifestyle. This is very important. We have already seen the possible mechanisms involved in the innate immunity, how vitamin D protects against the invasion of the organisms like virus. Vitamin D supplements, this is something that we have to remember because as dermatology, we see lots of cases of sarcoidosis. Vitamin D supplements in sarcoidosis may cause toxicity faster due to the high rate of conversion of the inactive vitamin D to active vitamin D3 because the activity of 1 alpha hydroxylase which converts 25 OHD to 125 dihydroxy vitamin D is increased in sarcoidosis. So in place of checking for 25 OHD, total 25 OHD, that is a normal test that we do for vitamin D, we should test in cases of sarcoidosis, we should be testing direct 125 OHD or dihydroxy vitamin D levels or PTH levels, the parathyroid hormone levels, before giving the patient any supplements with vitamin D. Now, this is there are many reports showing the beneficial effects of intralesional vitamin D in palmoplantar, very resistant palmoplantar and anal warts. This could be due to the anti-proliferative and pro-differentiation potential, and of course, induction of the antimicrobial peptides that you have seen. In many studies, this has been shown very effective. Just ingestion to larger warts causes disappearance of not only the wart at the injected site, even at distal sites also the warts disappear. So this is very important, and some studies have shown that intralesional vitamin D3 injection was found to be superior to even intralesional PPD, that is the tuberculin derivative, the tuberculin injection antigen injections. So this is also very important addition to the armamentarium of dermatologists. Now in the hair cycle, we have already seen the mesodermal papilla cells and the outer root sheath of the epidermal keratinocytes, which line the hair roots and the hair shaft, express both VDR and RXR. These both regulate the expression of genes that are required for the hair follicle cycling, especially the anagen initiation. Hence, it is very important to check for vitamin D deficiency in any form of hair losses. The role of vitamin D in hair loss might be explained by the fact that an optimal concentration of vitamin D has been suggested to be necessary to delay the aging phenomena, including hair loss. Recently, it has been shown that calcitriol and VDR promotes the ability of beta-catenin to stimulate hair follicle differentiation. Moreover, there is extensive data from animal studies showing that VDR activation plays an important role in the hair follicle cycle, especially as we have already seen, anagen initiation. There are also studies showing both a positive and neutral relationship between vitamin D and hair loss. Given the genomic actions of vitamin D and the presence of VDRs in the hair apparatus, it is indeed prudent for us to screen for vitamin D and supplement with vitamin D in cases of with deficiency during the management of all types of hair loss. Not only alopecia areata, not only telogen effluvium, even though there is not specific studies showing positive results in male pattern baldness, the androgenic alopecia, we should correct the deficiency of vitamin D if present. There are many less characterized roles of vitamin D in many other skin diseases like rosacea, seborrheic keratosis, skin aging, leg ulcers, Burchett's disease, PCOD, and autoimmune diseases. We will not go into details about this. You can search the literature. There are many studies, hundreds of studies involving all this and many more skin diseases. This is one of the first studies to show that genetic mutation in vitamin D receptors is associated with oral lichen planus susceptibility. This is something very interesting, but we need larger scale prospective studies and functional experiments to validate these findings, of course. In another double-blinded placebo-controlled interventional trial, a very interesting study, almost 20 healthy adults were randomized to receive either placebo or a high dose of vitamin D, that is the vitamin D3, 1 hour after experimental sunburn induced by an erythemogenic dose of UVR. Compared with placebo, they found that participants receiving vitamin D3, that is 200,000 international units, demonstrated reduced expression of pro-inflammatory mediators, TNF alpha, and inducible nitric oxide synthase in skin biopsy specimens 48 hours after experimental sunburn. This is very interesting. We can use high dose vitamin D to attenuate the inflammation caused by sunburns. Patients on prolonged systemic steroid therapy. This should be interesting to dermatologists who use lots of steroids in our day-to-day practice. Patients will on prolonged systemic steroid therapy will definitely benefit from concurrent vitamin D supplementation. That is, those taking more than 5 to 7.5 milligram per day of prednisolone or equivalent for more than 3 months should be supplemented with vitamin D and a multivitamin always. Now, finally, let us briefly glance through the vitamin D dosage recommendations. These are the normal and abnormal levels of vitamin D. Severely deficient, below 0 to 10 nanogram per ml. Deficient, 10 to 20 nanogram per ml. Insufficient levels, 20 to 30 nanogram per ml. Sufficient level, above 30, up to 100. And optimum levels, 40 to 60 nanogram per ml. The equivalent values are shown below in nanomole per liter. To convert nanogram to nanomole per liter, just multiply with 2.5. So the normal level of 30 nanogram per ml is equivalent to 75 nanomole per liter. And the high levels are above 100 nanogram per ml, not to be used usually unless you want to try in diseases like psoriasis to suppress, but along with the proper guidance and proper testing, tight testing of the levels of especially parathyroid hormone and the renal functions and the calcium levels, elemental calcium levels. This is very important. And unless you keep a close watch, never go higher than 100 nanogram per ml. Toxic levels above 150 nanogram per ml. Now, recommended dosage for vitamin D deficient replacement dose is 50,000 international units per week for 8 to 12 weeks, that 2 to 3 months, followed by every 2 weeks, once in every 2 weeks for another 3 to 4 months. Or alternatively, you can give 10,000 international units 5 days a week for say 2 to 3 months, depending upon the initial deficiency. If it is very deficient, you go for 3 months weekly, then go for every 2 weeks for another 3 to 4 months, and then go for the maintenance dose. Once the level becomes normal, normal means above 30, between 40 to 50, keep it near 50. If it is at that level, then maintain with either 50,000 monthly or 1,000 to 4,000 international units of vitamin D3 daily, depending upon the sun exposure. If the patient is going for sun exposure between 10 a.m. to 3 p.m., then the lower doses can be given, or the monthly dose can be altogether given up. If the patient is having regular exposure to sunlight for more than 15 minutes every day between 10 a.m. to 3 p.m., then there is no need for vitamin D supplementation unless and until he takes other micronutrients through the well balanced diet. So this is very important. Once we stop, there is no course for vitamin D. This is very important to tell your patients also. Most patients, it is not an antibiotic. Just think about it. It's not an antibiotic. It is a nutrient which is essential for cellular function, and it is a lifelong necessity. It is not like you eat and your hunger is gone and you stop eating. Then next day you don't stop. You don't again say, because yesterday I have eaten, I will not eat. It's not like it is the same. Antibiotic you give for 5 to 7 days. Once it is finished. That is a course. There is no course for vitamins, vitamin D and other nutrients. It is lifelong. So only thing is, once you reach the normal levels, you maintain it with a normal dosage. If you stop it again, the patient continues the same lifestyle, it will go back again. So it will be useless. In the long run, the patient will continue suffering from major illnesses because of lack of support from the cellular um, hormones as well as the cellular micronutrients. So higher doses. Sometimes I've seen many patients getting injections even for levels at 20 nanogram or 30 nanogram. This is not required unless the patient is severely ill and the deficiency levels are below 5 nanogram per ml, or say below 12.5 nanomole per liter. Then you can give injections. Injections need not be quite often. One injection is sufficient for 1 month, and after that, after about 2 to 3 weeks, you can start the patient on the oral vitamin D3, that is weekly dosage, for another 3 months, then every 2 weeks for another 3 months, then maintenance dosage depending upon the sun exposure. Contrary to popular belief, vitamin D deficiency is rampant all over the world, and even in a sunny country like India. With the prevalence in India, the prevalence of deficiency ranges from 40 to 99%. It is similar in many countries, especially in temperate climates where the sun exposure is less. The sun rays fall in a very low latitude level. Their deficiency levels are much higher than this. So you can imagine the problems created. Why there is the increased rate of cancers? Why there is increased rate of lifestyle diseases? Why there is increased rate of allergies? Why there is increased rate of infections? Why so many millions are affected by pandemics like COVID? Could we limit or prevent these pandemics from uh, keeping the whole humanity under ransom by keeping a normal good level of vitamin D and other micronutrients? Yes, the answer is yes. Yes, it is coming. So many studies are coming. In the early 20s, when I first gave the talk on vitamin D and COVID-19, at that time there were not many studies, and many people were a little hesitant about to accept that. But now many studies have come up that people with normal vitamin D levels and having a healthy diet, leading a healthy lifestyle, actually do not go towards the moderately severe or severe type of illness in COVID-19. So when we list out the morbidities of that is responsible for severe COVID, like hypertension, like cardiovascular disease, like diabetes, like cancers, like immunosuppressive drugs. I think the first morbidity that should be kept is nutritional deficiency, including vitamin D deficiency, iron deficiency, and other vitamin deficiencies. I've seen many patients receiving vitamin C, only vitamin C. That is not sufficient. The first thing that you should supplement is vitamin D, then vitamin C, zinc, and multiple vitamins. And tell the patient to follow a healthy lifestyle. This is the only thing that will help in future. Vaccines will help to prevent this pandemic or control this pandemic. That is also we are getting doubtful now up to a limit because there are so many variants, mutants coming, and vaccine effectiveness may be limited there also. We may have to go for other vaccinations. But our inborn vaccine, the immune system, which is driven by proper nutrition and a healthy lifestyle, is the most important thing that will keep us safe and protected from this pandemic as well as the future pandemics. This is a very surprising study among even health care professionals in India. Only 6% had above normal levels of vitamin D. No comments on it. Importantly, many people, as in many people are afraid to take vitamin D, telling it can go into toxicity. This is very, very absurd. Just like saying you will drown in water if you drink a glass of water for when you are thirsty. It's as absurd as that. Vitamin D toxicity is very, very rare. It's very rare. And vitamin D deficiency is very common. So you know what to do. Don't be afraid of vitamin D toxicity. Vitamin D toxicity occurs exclusively in people who take long-term high-dose supplements without monitoring their blood levels. I heard many doctors telling, no need to, everybody is deficient, no need to monitor. You just take vitamin D. It's not correct. Personally, I feel it's not correct. Okay, in some places the cost is very high for vitamin D. What we should do is to try to make vitamin D level testing cheaper instead of telling patients don't do the vitamin D levels. Personally, I tell my patients this is the importance of vitamin D. If you do it, well and good, but because of you cannot afford it, okay, then let us take a optimum levels. I will never give them high levels. Without knowing the blood levels, I never give any patient high vitamin D dosage. Only normal dosage, 1,000 to 4,000 international units per day. That is the normal thing that I will give. Or 10,000 units per week. If I could not check the levels. Once we check the levels, we are safe. We know if the patient is hugely deficient, go for higher doses for a longer duration. Once 6 months is over, if we can afford, again check. Once it is normal and you review the lifestyle and eating habits of the patient, then you decide on the further maintenance dosage. This is very important. And vitamin D, you should remember that vitamin D intoxication occurs above 150 nanogram per ml, that is 375 nanomole per liter. In contrast, you cannot reach dangerously high blood levels through diet and sun exposure. This is very important to remember. Only supplements will cause high dosages. So telling the patient who is very afraid of getting intoxicated after the normal levels, you go for sun exposure, because after a certain level, more sun exposure will actually reduce the amount of the active vitamin D. Calcitriol levels will be actually reduced because it is converted into inactive products. So that may be why we get many patients, laborers who work throughout the day in sun. They come with vitamin D deficiency because their active and circulating vitamin D is converted into inactive forms. One. Second, they don't take a balanced diet. So naturally, their protection from that sunlight is gone. So sunlight, too much protection, too much exposure. We know we have to balance between, especially those with fairer skin, have to balance between the sun exposure causing the skin cancers and the vitamin D production. And a few studies have been done to see the effect of sunscreens in blocking the ultraviolet rays so that the vitamin D synthesis is reduced. But most of the studies show that application of sunscreens, usually people apply only on their face and some full body when they go for sunbath. But that protects from to a limit, not completely, to a limit, from the skin cancers, the harmful effects of UVB, but rarely does it reduce the vitamin D synthesis. So, for those with fairer skin, the advice is you expose to sunlight in a minimal manner with the proper sun protection, sunscreens, and don't worry about vitamin D deficiency. Keep checking every 6 months. If it goes below lower level, take supplements or take fish, the vitamin D containing food properly, regularly. Uh, Another thing that we have to remember is, because the vitamin is stored in the body fat and released into the bloodstream slowly, once the patient reaches the toxicity level, then that it will take a long time for the toxic levels to go. So it is very important to see, to put the patient on hypocalcemic diet to reduce the calcium levels, and put the patient on continuous hydration, and also see that the renal functions are kept normal. The sources of vitamin D we have already seen. Ideally, we should get 80% of our vitamin D from sunlight. If not, it is not possible, then only from supplements. Food, of course, you can complement with the sunlight. The problem with vitamin D through supplements is, as we have already seen, we do not know. Once we take the supplements, we are only checking 20 the inactive vitamin D3 levels, 25 OH vitamin D3 levels. This may not clearly show the exact amount of vitamin D3 in our body, because there may be some stored in our fat also. So continuing to take higher doses of vitamin D supplements for a long time without checking may cause a problem of the toxicity. So this may be why many people are afraid to continue. No, please remember that once you reach the normal levels, if you are going for normal sun exposure, then you don't have to take supplements. If you are not going for normal sun exposure, the levels will again come down. We have already seen the level of the circulating 25 OHD half life is 15 days. And if certain amount is stored in our fat, this can be extended to 2 months. But this is very rare for most people because they don't expose to sunlight that much, and excess exposure, of course, inactivates the vitamin D3 also. Now, the foods and supplements that are high in vitamin D, we have already seen the cod liver oil, fatty fish, egg yolks, and mushrooms. These are the normal foods, and of course, the fortified food, milk and yogurt and cheese, orange juices in some countries, cereals in many countries. These are all fortified with vitamin D. And for vegetarians, pure vegetarians, the sources are very low except from the food, the fortification. They get only from sun-grown mushroom mainly. But the choice for the non-vegetarians are very high. So pure vegetarians always make a habit of checking for their vitamin D at least once in a year if you are not taking the supplements, as well as vitamin B12 also, which is also mostly deficient in the purely vegetarian people and vegans. And if you are not, if you don't mind, you can even take the cod liver oil capsules instead of the so that you will get not only vitamin D and A, you will get some omega 3 also. There are a few medical conditions where vitamin D supplementations may have adverse effects. Sarcoidosis, we have seen already how it is. History of renal calculi, because hypercalcemia can cause renal calculi. Uncontrolled endocrine diseases is another contraindication. Of course, hepatic and renal diseases can cause problems in high vitamin D supplementations because it cannot be converted to the active forms and also sent to our body fats. The serum levels of circulating vitamin D can shoot up in such conditions. So we have to be very careful and monitor the levels if we are giving supplements. Now, before ending the talk, I would like to, as I have promised earlier, a few words about the controversies for and against. There are many controversies. You can see many studies supporting the role of vitamin D in psoriasis, in vitiligo, in atopic dermatitis, almost every disease, not only skin, as I told you, in every disease, in cardiac diseases, diabetes mellitus, cancers, autoimmune disease, everything, everywhere, hair loss, everywhere. But there are a few studies also showing that there are no effects. This is a little foolish to think about. These studies, though they are, I'm sorry to say, sometimes the evidence-based medicine can mislead us. How can we show a particular uh, nutrient which is essential for our cell for its normal function is not needed in any disease, let alone psoriasis or vitiligo, any disease? No, for a healthy life, for a healthy body, for a healthy mind, even this all um, also affects our brain functions and neurological functions as well. So, as we know, what could be the reason? The reasons are multiple. Mostly, the most important thing is most diseases are multifactorial. Though we are talking about vitamin D today, it does not mean vitamin D is the only cause for all these diseases. No, vitamin D deficiency is only one of the main causes, main factors, and it's an essential factor also. Hence, only studying vitamin D effects in such and such disease will not show real results. How can it show? If in psoriasis you give high doses of vitamin D and then say psoriasis is not improved, how can it be true? Psoriasis can be caused by so many factors. There are so many other triggers for psoriasis, including stress, infections, other immune related problems. So how can you just say just by giving it is not effective, so it is not effective? No, it is like saying electric machine, which has been running on low voltage. Once the machine breaks down because of low voltage, will providing high voltage again or normal voltage again make the machine work again? No. Already the pathology has happened. Once the pathology happens, the preventive aspect may not work there, unless of course it is in rickets. or osteomalacia, where it is specific vitamin D deficiencies causing the disease. Other diseases, they have gone into their inflammatory phase. The inflammatory cascade has been opened up. And vitamin D, for example, it may only help in certain steps. It may not cure, or it may not help in curing like the biological agents to stop the progression of the disease. No. So it is more important to remember that the role of vitamin D is more of preventive and arrest of progression of any disease rather than curative aspect in most diseases. The results of inflammatory injury may not be repaired with vitamin D deficiency or all other triggering factors, unless, of course, what I meant to say is this may not be corrected or cannot be arrested. The further progress cannot be arrested unless vitamin D deficiency and other triggering factors are corrected. This is very simple to understand. And how can we say that vitamin D, after giving vitamin D for certain number of patients, this is not working, so vitamin D is not necessary for psoriasis? Very absurd. So let us not completely be driven away with such negative reports about not only vitamin D, any nutritional essential factor of cellular function. This is necessary for our body to work and also to control any diseases. And another thing is vitamin D, as we have seen, is not a standalone nutrient. It works in coordination with other micronutrients, as we have already seen. So just by giving vitamin D and seeing that it is not working and it is not enough is again another negative point about these studies. Now, about the metabolism and conversion of vitamin D to its active form requires both the heat from sun exposure and a well-balanced diet and a good lifestyle. This we are telling again. I am repeating again and again because it has to go inside even the minds of our doctors, who I have seen as a senior doctor. I've seen many doctors not asking about the dietary history, the life history, the most important things that we should take in each and every disease. We may not have time, but at least ask the patient, do you eat a well balanced diet, and do you do regular exercise and take rest and drink lots of water and expose to sunlight? These 4 5 things immediately within, I think it requires hardly 2 minutes to take this history. If they are not, if the history shows low quality lifestyle and food style, go for testing, then correct the deficiency. This should be our approach, rather than telling vitamin D is there everywhere, everybody has got deficiency, so why worry about it? And those who are not deficient also get diseases, so vitamin D is not. This is not correct. That is not correct. Not only about vitamin D, for everything. So let us correct our that paradigm shift from our these types of wrong beliefs and wrong concepts about the what do you say, the evidence-based medicine. Evidence-based medicine should not stop us from forgetting our basic metabolic and basic physiological functions of the body. Now, the final question is, should vitamin D be scripted in each and every prescription? Being an essential nutrient, I would say it should always be tested in all chronic dermatology patients and corrected. So, in all chronic diseases, you should make it a point to check for vitamin D and, of course, the other nutrient levels, whichever is possible. But vitamin D is an essential must, and it should be corrected. We have nothing to lose, but much to gain. Our patients, they may gain a lot when the insurance companies do not approve the vitamin D levels. I really flabbergasted at their short-sightedness. Actually, what they should be doing is they should have a full checkup when any individual takes up insurance. Vitamin D levels, the iron levels, the thyroid levels, and the vitamin B12 levels, and a total checkup of all the systems. Once any deficiency is there, correct it. They will see that there in long run, within 3 to 5 years, the amount of expense for treating the patient for allergies, for infections, for chronic diseases, for lifestyle diseases comes down. This is what we should be doing. This is what any government which has got the public health in mind should be telling the insurers and telling their population to follow. So let us hope this catches up, and we as doctors have to give this message to the society about this. Even not only in chronic diseases, even in acute infections and allergies, correcting any deficiency will be beneficial for the patient. Now, the take-home message is vitamin D is not an optional supplement. It is a non-negotiable cellular necessity, because it is an important part of our life support system. So let us all keep ours as well as our patients' vitamin D levels at an optimum level, not only for our skin but our overall body health. Thank you very much for this patient hearing. I hope this was useful not only for dermatologists, all other doctors and healthcare professionals, and for the science loving public out there. Thank you. Take care.